Good afternoon, everyone. Welcome to DeBakey CV Live. We are having part 2 of contemporary management of chronic thromboembolic pulmonary hypertension today. We had part 1 of this talk on October 31st, 2019, and you can find the video already on YouTube. So today we have with us Brian C., who will be discussing the case, and I am Ashrith Guha. I'm a heart failure transplant cardiologist and a pulmonary hypertension specialist. Dr. Zeenat Safdar, who is a pulmonologist and a senior pulmonary hypertension specialist. Dr. Mahesh Ramchandani, who is our senior cardiac surgeon and our surgeon for pulmonary thromboendarterectomy, and Dr. Lin, who's an interventional cardiologist and adult congenital heart specialist, as well as someone who does all our pulmonary angiograms and our balloon pulmonary angioplasties. The objectives for this afternoon are to review pulmonary angiography's role in the assessment of CTEPH, and assessing operability in CTEPH, and role of balloon pulmonary angioplasty, and residual pulmonary hypertension after PTE surgery, and role of medical therapy in CTEPH. So we'll get started now with a case presentation by Dr. C.
So we have a 59-year-old female with history of renal cell carcinoma, anxiety disorder, hypertension, who initially presented to us with dyspnea exertion with class 3 symptoms, and has noticed a gradual decline in her exercise tolerance. She is now only able to walk about 1 to 2 blocks before becoming short of breath. And over the course of the last few months also had been developing worsening bilateral lower extremity edema and swelling of the abdomen, and physical examination was consistent with findings for high pulmonary pressure, as well as right heart dysfunction. So she had undergone all of the testing associated with the diagnosis of pulmonary hypertension. The pulmonary function test did not reveal any significant abnormalities. CT of the chest didn't reveal any parenchymal abnormalities, and the echocardiogram showed that there's a elevated pulmonary artery pressure as well as right heart dysfunction.
So we have a VQ scan here, and we'll get Dr. Safdar into the conversation here. Dr. Safdar, do you want to interpret the VQ scan?
So one thing for Claire is that VQ scan is not normal. You can appreciate that the edges of the VQ scan or the perfusion scan doesn't go, the dye is not evenly distributed, and there are areas where the perfusion is blocked off or is missing. So mostly in the right upper lobe, the right lower lobe, also in the left upper lobe, you can see areas of wedge-shaped perfusion defect in this scan.
So, when you see somebody like this who has an evidence of pulmonary hypertension on echo with RV systolic pressure of 70, and then an abnormal VQ scan with multiple mismatched abnormalities, I think the next step would be a right heart cath with pulmonary angiogram.
So this patient did undergo right heart catheterization, which showed high pulmonary pressures associated with pulmonary pulmonary vascular resistance, as well as a normal left-sided filling pressures, which essentially rules out group 2 pulmonary hypertensive disease.
And I'll have Dr. Lin talk to us about the pulmonary angiogram.
Right, so actually, thinking about the way we do our hemodynamic assessment, One of the things that we learned early on that's really important is that we really need to understand what the left-sided pressures are. So in other words, the left heart pressures are. Because we make the assumption that the wedge pressure gives an accurate evaluation of the left heart pressures. And unfortunately, when you have fairly significant CTEPH, what may actually happen is when you float the balloon flotation catheter out into what would normally be a wedge position, and actually doesn't get to the wedge position and doesn't actually wedge, and so therefore you don't necessarily get an accurate assessment of the left side filling pressures. And so what that means then is you can't calculate an accurate pulmonary vascular resistance. So in order to ensure that we actually get the right hemodynamics every time, we actually go ahead and do a left heart catheterization simultaneously doing our right heart catheterization, just in case the CTEPH is significant enough that we can't actually wedge the catheter. So we typically like to do to take an internal jugular venous approach and a radial approach for our right and left heart catheterizations, because typically many of these patients are anticoagulated, and we'd like to try to do the catheterization with uninterrupted anticoagulation. As most people listening know, this is a situation where you can control access site bleeding if there are issues if you use the internal jugular vein and the right radial artery access site, and we use ultrasound guidance for both those accesses. So we begin with our hemodynamic catheterization. Once that's complete, I learned our technique from the UC San Diego team for our diagnostic angiography. And so typically what we use is we use a balloon flotation angiographic catheter for our diagnostic angiography. And what that is, it's called a Berman catheter. We'll either use a 7 or an 8 French Berman catheter. And what's nice about this is it's typically very atraumatic and doesn't require a wire exchange. So what that allows for is an atraumatic advancement of an angiographic catheter out into the distal, either right pulmonary artery or the left pulmonary artery, depending on where you're going. And allows you to do power angiography. And typically, as you see here, we use digital subtraction angiography to really optimize our sensitivity for a non-specific pulmonary angiogram. And so what you get here is you get enhancement of the entire pulmonary tree on one side or the other. And what you see here is we're in the left lung, we're using an LAO and a lateral projection to give us an optimal understanding of both the left lung as well as the anterior and posterior relationship, because that's a really critical part, a critical piece of information that we need to give the surgeon so they can understand which lobe is affected the most and which arteries are affected the most prior to surgery.
And can you comment a little bit on the importance of doing a lateral projection in these pulmonary angiograms?
Absolutely. So just like with coronary angiography, multiple views are really important. In coronary angiography, you've gotten a good sense of understanding what the coronary anatomy is based upon the multiple projections that we use. However, in the lungs, it becomes very important to have a sense of anterior and posterior relationship, because of course the lungs are a very complicated three-dimensional structure, and understanding the 10 different segments of the lungs requires having a sense of the anterior-posterior relationship. And the only way to get an anterior-posterior relationship is to actually do either a far LAO projection or a lateral projection. And so typically what we do then for the right lung is to do an an AP projection and then a lateral projection. So that'll give us left, right, or medial lateral relationships, and then anterior and posterior relationships of the affected vessels. And then likewise, as I mentioned before, for the left lung, we'll use an LAO projection and a lateral projection to give us the same thing. So the left, right, or medial lateral relationships, and then the anterior posterior relationships, so that we can define which segments of the lung are actually most affected.
And do you want to walk us through what you're seeing here in the left pulmonary angiogram?
Right. And so what you're seeing right off the top is, of course, this is a balloon flotation catheter that's been advanced into the left lung from the right internal jugular venous access site. And what you see here is this is digital subtraction angiography being performed. Obviously, the patient has to be able to cooperate if you want to do digital subtraction, because they can't breathe during the angiogram. If they move or breathe during the digital subtraction angiography, then you get some blurring, and that's partly what you're seeing here. There's a little bit of blurring because the patient moves or breathes right in the middle of the angiogram. So what we're looking at here is we can actually see that there are multiple segments of the left lung that are affected by CTEPH. And specifically, what we can see is that there's a dearth of perfusion of multiple segments of the left lung. So If you look at the lateral projection on the right side of the screen, what you can see is you can actually see that there's a very marked paucity of perfusion of the mid segment of the posterior part of the left lung, and that is typically associated with A6 or the superior segmental. We're having some technical difficulties with our angiography playing. But either way, so knowing this case, I actually know it fairly well. There are multi-levels of CTEPH involving the left lung in this particular situation, and so we can see sort of pretty much from type 2 to type 4 level of disease. What we saw was not only some elements of proximal mid-segments of lesions, but also severe pruning of the distal vessels involving the left lung. In reality, we'll actually look at some specific lesions and lesion characteristics in a couple slides down the line, so we can actually talk about what the optimal treatment regimen is for those, whether it's what the best mechanical treatment regimens are for those, whether it's potentially BP appropriate for BPA, for balloon pulmonary angioplasty, or best treated with surgical thromboendarterectomy.
So I have a question. Do you do the right heart cath and the pulmonary angiogram at the same time, or do you do them in two separate settings?
So during the same session, we use a different catheter. So you can actually use the angiographic catheter to measure the hemodynamics, but of course, as we mentioned, we like to have both the wedge and the LVDP. So I typically like to use an end-hole catheter for my hemodynamic measurements. I can't use the Berman catheter to get a wedge pressure.
We were reviewing the left pulmonary angiogram. We'll review the right pulmonary angiogram now. Dr. Lin?
Yeah, absolutely. So first, what you're seeing here is the lateral. And what's actually really nice about this is you see a very nice breakdown, especially because there's so much disease in this patient. You see a very nice breakdown of the anterior-posterior relationships. And then here on the anterior-posterior view, what you're seeing is the very first branch, the interlobar artery. Moving target. On the lateral now, you can actually see a paucity of vessels throughout the entire lung. So what you see is the very first branch that comes off of the right lung is dead ends, and there's really no flow distally. And then what you see very nicely on the lateral is multiple branches anteriorly do the same thing. So those are the middle lobe branches as well. And then finally, what you see is in the lower lobe branches that you see a paucity of vessels distally. And so what this really suggests to us is that we have multi-level disease in this patient, really primarily in the distal segments of the vessels. Can we play that one more time? And what we can do is we can actually see, what's really nice is when you actually see this angiogram, you see that when you look going out into the parenchyma, that there's a really paucity of flow out into the parenchyma. And that gives you a sense that there's pretty marked CTEPH throughout all segments of this right lung. You can see how the dye just doesn't quite reach the pleura. And that's kind of the marking that we usually are concerned about, suggesting that there's really hypoperfusion.
Then I think we'll go to the next slide, where I think we can talk about the kind of lesions that we commonly encounter, and which can give us some kind of prognostic, and also in terms of what we are going to be able to do about them.
Right. So type A is the ring-like lesion, and so for us interventionalists, this is kind of the ideal lesion because it's the outcomes are better when we intervene on these types of lesions. The same goes for web lesions. It's a little hard to see on this projection, but typically what you see is sort of a hazy segment of the vessel that suggests that there's kind of a web there, and that multiple operators have now seen on OCT confirming that, as well as of course the histological samples. Then C and D are the subtotal and total lesions. And those are kind of a little bit higher risk for intervention from a balloon pulmonary angioplasty standpoint, as is E, the tortuous lesion. And these figures are actually from Dr. Matsubara's team in Okayama, Japan, who really sort of started defining what the risk factors are related to balloon pulmonary angioplasty, and much of that comes from the actual lesion characteristics that you see here.
So I think from this, we can transition to the the elements of diagnosis that you really are going to get from pulmonary angiogram and also additional testing. So I think one of the things to look for is whether this is CTEPH or a mimic, and oftentimes it is difficult to just find that out based on pulmonary angiogram. And I think that's where a CTP protocol or CT with contrast would be helpful.
Absolutely.
So do you do the CTEPH protocol in every patient that is being evaluated for CTEPH?
I think here we have transitioned to doing that in all the patients because we feel that it gives us additional information in addition to pulmonary angiogram, and we often end up doing it before because it does help us almost confirm our diagnosis.
And also to rule out maybe the CTEPH mimics that you're talking about,
correct, like sarcomas and vasculitis. And again, with the pulmonary angiogram, you're going to look at lesion type like Dr. Lin described, and then the segments involved, and whether it's surgical or non-surgical disease. And Mahesh, do you want to comment on what you would look for in a pulmonary angiogram to decide whether it's surgical versus non-surgical disease?
Well, broadly speaking, you can divide the level of disease into 4 levels. Level 1, which is the most proximal, level 2, which is further out, and level 3 and 4, which are segmental and subsegmental disease. And it's not hard to understand that the more distal you get, the more difficult the operation can be, and the less likely you are to get the kind of result that you're hoping for, which is a very significant drop in the pulmonary arterial pressure. This patient appears to have what I would classify as level 2/3 disease, and I think would be a good surgical candidate. And would be reasonable to consider for surgery purely from the angiographic findings. Now, obviously, there are many other considerations that will determine whether a patient is a suitable candidate for surgery. And broadly, you can divide those into 2 groups: general considerations and specific considerations. General considerations are things that you would take into account for any kind of major operation, and frailty is probably the most important one. Better and better ways to assess frailty now, but ultimately a personal assessment by the physician is still, by an experienced physician, is still probably the best way of doing it, and the way most of us still do it. The existence of concomitant disease, bad lungs, bad liver, bad kidneys, bad brain, previous stroke. So it really depends upon the severity to which it occurs. So if the dysfunction is mild, then they wouldn't necessarily be, surgery wouldn't necessarily be contraindicated. But if it was mild and you had several organs that had mild dysfunction, then you might be a little bit more concerned. So that's something that's, I would say, falls on a sliding scale, and is one of the reasons why having a team that can sit around and talk about these things becomes very important. Specific considerations deal with technical issues that relate to the particular operation. And there aren't any real absolute contraindications, but there are relative ones. So, for example, if they have an extremely bad right ventricle, and you may want to comment on how difficult it can be to properly assess the right ventricle preoperatively, because I think that's a very important consideration from a surgical standpoint. But that's one issue that you'd be concerned about. Is it a redo? Well, it doesn't necessarily mean that that's a contraindication, but obviously it raises the risk a little bit. And of course, the level of disease that we have spoken about. So I think broadly that's
yeah,
how.
And like you were saying, I think when is the right ventricle too far gone? I think that's always very difficult to assess, and especially in patients who have very low cardiac outputs to begin with, and very low, markedly dilated RV, and who've presented late in the disease. Those are the patients who probably would benefit the most, but at the same time, you are not really sure of how much distal disease they have. And these are patients who might be left even with significant residual pulmonary hypertension after. That's something that we'll talk about later in the in the discussion. But you're absolutely right that I think the degree of right ventricular dysfunction is, we have used MRI sometimes in some patients, the difficult ones, to really get a more quantitative assessment of right ventricular dysfunction, but it is often very, very difficult. And I think there is some data, and we've used it a few times, where we've done nitric oxide challenges to see if with decrease in PVR, if there is an increase in cardiac output. I think that does help a little bit in trying to determine whether RV function will improve after surgery. But still, I think there are no clear answers there. Like we were discussing, I think hemodynamics play another role in deciding operability. If the PVR is way too high for the level of disease that they have, then you have to think about whether patients have level 4 disease, which is small vessel, which are really not amenable to any
right.
Whether catheter-based or surgical intervention.
Right. It's the data do in fact show that for people with extremely high pulmonary vascular resistance, the mortality from the operation is higher, but it's important to note that it doesn't contraindicate doing the surgery, because you're looking at maybe a 5-6% mortality versus a 2 or 3% mortality rate. So it's a significant increase, and it's something that needs to be taken into account.
And also duration of the disease, how long the patient has had CTEPH before they came to you and have this assessment done. So if the longer the duration of the disease or time to diagnosis, the worse the outcome is going to be.
So going through the treatment algorithm for CTEPH, I think our patient was offered surgery, and do you want to share with the audience, what she decided? And
So I think Dr. Ramchandani was saying that this patient would have been a reasonable candidate from a technical surgical standpoint, but the patient actually ultimately decided against surgery and didn't want a referral to UCSD. So then the next part in the decision pathway is then to decide whether medical therapy versus a balloon pulmonary angioplasty was the best choice for the patient.
So before we switch gears, I wanted to let everybody know that they can text question to us. So you can text DeBakey to 37607 to join, and then you can text our questions. We have questions coming in, and maybe we can use this break to maybe answer a couple of them, and then we'll try to answer them, some of them later on. So one of the questions was, would you say dual energy CT and MRA add to the diagnosis and prognostic information? And I want to get Dr. Lin's opinion here on that one.
So we have the capability of doing dual source CT, but we're not using it yet. I've seen the images. I think it's going to be fantastic. So let's clarify what I'm talking about. So dual source CT actually allows you to get not only the anatomical data for the angiography, so the CT angiography, but it also actually allows you to actually get perfusion in a 3-dimensional format. So what that allows you to do is basically take the same perfusion data you typically get from say a VQ scan, and actually have it in a cross-sectional imaging type of data set, and have it overlaid on top of your CT angiogram. So that gives you anatomical and perfusion data at the same time, which of course we now know in the coronary space is really critical. But here, I think for us interventionalists, as well as I think the surgeons, I think it really gives you a sense of how much bang for the buck are you going to get if you go after that particular segment of the lung. And I think that is very rewarding to know that. And I definitely know that the team at Temple is using it, and using it to very good effect for cath lab planning. And I think that really helps you to sort out what are your priority lesions. And I think MRA also has a really great role. We don't use it very much, at least I don't typically use it very much for my practice. I think when it's available, it's very useful. But I think once you get into sort of the third order branches, it really has some degree of limitation from the resolution standpoint. There is some very interesting data coming out as far as using lung perfusion MRI. So it's basically an MRA in which you can give a bolus of a small amount of gadolinium and track it in real time as it goes through the lungs. And that can actually give you perfusion data without actually the use of, say, a technetium tracer. So I think that'll be really interesting. Will be very intriguing to look at for clinical validation as we get more data from that standpoint.
And another question that we have is, and this is, I'd like to get Dr. Safdar's thought here. How many patients with pulmonary hypertension go undiagnosed for CTEPH?
You know, there's no real data that we know about. There's a CTEPH registry happening now, and that will give us more data of how many patients actually get undiagnosed and go undiagnosed being treated as PAH when they actually have CTEPH. So right now we do a VQ scan for everybody that is diagnosed or newly diagnosed with PAH. I think that is the recommendation, and that's how you pick up all those undiagnosed cases, is by doing a VQ scan. Some people believe that doing a CTA is good enough, and I think data suggests that that does not have the sensitivity and specificity to diagnose CTEPH, and we actually need to do a perfusion scan to look for perfusion defect to diagnose the CTEPH.
Okay. So I think we'll continue with our discussion here I think I'd like to draw Dr. Lin again into the BPA that we could consider for this patient, and do you want to talk about what has?
So balloon pulmonary angioplasty was initially described in the Netherlands in 1988, and in 2001 with the Harvard group was kind of one of the first bigger series that described the outcomes of pulmonary balloon angioplasty in patients with CTEPH, and we can see that on the right side of the screen that with regards to their functional capacity, that most of the patients actually did fairly well, and with their angiographic findings showed a significant improvement as well. But I think for the next slide we'll see that, and I think Dr. Lin will be able to comment on this more, is that balloon pulmonary angioplasty, although it can be effective, it's not without its risks, and there can be a lot of associated complications.
Dr. Lin, do you want to
right. So I think one of the really interesting things is there's been some really great data from again the Okayama group as well as the Tokyo group, and actually trying to understand what exactly happens when you're doing balloon pulmonary angioplasty. And I think that's the critical element to understand what's actually happening. So it actually turns out, just similar to coronary angioplasty, that it's a controlled dissection that occurs. And so what those very experienced operators have learned is that instead of going for a complete resolution of the lesion, so going back to angiographically normal appearing vessel, or even overdilating the vessel, what they've found is that all they need to do is create a small channel when they achieve their balloon pulmonary angioplasty. And what they found with this is that they can actually significantly improve the flow when they come back and perform repeat angiography and repeat right heart hemodynamics a couple months down the line. Some of the other operators have actually tried to define better what are the things that really help us to understand what the outcomes are going to be after balloon pulmonary angioplasty, because as many of you probably know, the outcomes of balloon pulmonary angioplasty in the early phases have been very challenging, with a number of complications such as hemoptysis, to the point where patients have actually required ECMO. And so to really define that, as we described early on in the conversation, that there are certain types of anatomy, specifically the tortuous lesions, the subtotal lesions, the chronic occlusion lesions, that really are hallmarks for potentially higher risk interventions. So that's what the Okayama group was able to really show. And then one of the other groups was able to start to define this classification, that's called PEPC, which is to understand the pulmonary, understanding what reperfusion pulmonary edema is going to look like, or what is the risk of reperfusion pulmonary edema. And the concept here was to try to understand how far should you take the intervention. In other words, if your pulmonary vascular resistance is X, how far should you get it to with Y? And another group has actually started looking at understanding, can you predict that using the distal pressure in the pulmonary artery of interest, using pressure wire interrogation pre and post intervention. And I think the sum total of all this is to understand that we don't necessarily want to completely normalize. So in other words, you don't want the gradient to go to 0 with the intervention, because if you take the gradient to 0, that segment may actually be more likely to develop reperfusion pulmonary edema or hemoptysis. And so I think slowly the field is really building a data set that will help us to understand who should actually get intervention, which lesions should we intervene on, and how much should we intervene on these lesions to achieve what we think will give us success.
Thank you. So I think switching gears, from BPA, like our patient, this patient had really two options, right? One was BPA versus medical therapy, and as you all know, we'll talk about a little bit later that riociguat was, approved for patients who've had pulmonary hypertension after PEA and also in inoperable patients. But what about using medical therapy before endarterectomy, Dr. Safdar?
The best option, you have to go for the best option for the patient. So the best option would be to go for surgery. And if you're going to put the patient on medication, that may delay the time to surgery. That's the data has shown time and time
Absolutely,
again.
and that's what we are seeing on the slide too, that it just delays presentation to the center, delays operability.
But if I would say, if a patient is in severe right heart failure, and the time that is going to take for you to refer the patient to the center will be a few weeks, so might as well start them on medication, get their RV in better shape, so they go through the surgery. So that's another option that should be looked at.
Mahesh, I want to get your thoughts on how you feel about operating on patients who are already on pulmonary vasodilators. I know there's some debate in the field about...
There is some debate in the field about whether or not it changes the qualitative nature of the intima and the plaque that one is dealing with to make it more friable. It's not at all settled that it does make a difference. In fact, it is likely that it doesn't make a difference. The folks at San Diego did an informal look at this in their own data, where they blinded the surgeons to whether or not the patient had been on riociguat preoperatively or not, and then asked the surgeons to provide a qualitative assessment of the kind of plaque that the patient had. In other words, to guess if the patient had been on riociguat or not based on what they found at the time of surgery. And they got it right just as often as they got it wrong. Okay. So that tells you that it probably doesn't make a difference. And I think if there are other reasons to use it, like what Zeenat had mentioned, then I think one shouldn't hesitate to.
Yeah, especially I feel that if you have a horrible RV failure with end organ dysfunction, whether
Correct.
improving the liver or improving the kidneys, I think it would be a good thing to do prior to surgery, so that they go in a much better shape for surgery.
And none of the interventions that we do, whether they are BPA or surgery, are free of risk. And this patient that we've just been talking about, for example, we feel confident would benefit from an intervention, whether it's surgery or BPA. But obviously she's been counseled appropriately, and she's aware of the risk, and she doesn't want to take that risk, which is which is fair enough. I mean, everybody has to make that decision. So in those instances, what do you tell patients? Because this is an important question that I think pops up quite often. It's that if I don't have an intervention like you have recommended, what is the natural history of my disease going to be versus if I did have an intervention and didn't have a complication? So what would you tell them?
There is no data per se or randomized clinical trial looking at surgery versus, and we will have that data coming out of CTEPH registry, but right now, as of now, we don't have that data. What we do know is that CTEPH is a progressive disease, so patients who have the disease, they will progress over time. Now, what you're trying to do as a CTEPH expert is trying to put them on medication, delay the progression of disease. It will depend on how the patient is going to respond. And I think one thing to remember is that not just giving them oral therapy, but also giving them intravenous vasodilators or prostacyclin therapy. That is going to delay the progression of their right heart failure, keep their PVR manageable so their RV is not tanking or not going into frank right heart failure. I think that's one of the most important things that we need to do and remember, and also to refer these patients earlier on to a center which have expertise in dealing with these complicated patients.
Yeah.
So we'll talk about risk stratification in patients with long-term outcomes after pulmonary endarterectomy. And This is really about recurrent PH after PEA.
So there's a group in the United Kingdom that looked at 800 consecutive patients who underwent pulmonary endarterectomy between 1997 and 2012, and what they found is that there's not an insignificant proportion of people who still have some degree of residual disease even after surgery, and in fact, so 51% of people had a mean PA pressure that was greater than 25 on right heart catheterization at 3 to 6 months, and from that time point on, the hemodynamics tend to correlate going forward. They noted that in patients who had normal hemodynamics after their surgery and were asymptomatic, they tend to do quite well, but the people who had some degree of residual disease tend to do more poorly and had more morbidity and mortality. And so from a risk factor standpoint, I think we can see that in general, more severe disease from a functional standpoint, from a hemodynamic standpoint, all of those tend to suggest that the surgical outcome may not be as good, but that doesn't necessarily mean that they shouldn't undergo surgery, because they still get significant benefit even if the surgical result isn't entirely curative per se.
So I think this sort of segues into what was a real landmark study, which was CHEST 1, which looked at riociguat in patients who are deemed inoperable, and when they say deemed inoperable, at least there were 2 centers which probably were asked whether the patient was inoperable, and then in patients who had recurrent pulmonary hypertension after PEA and who all had PVR greater than 300 dynes, which kind of translates into about 3.5 Woods units, and mean PA pressure over 25. And patients were excluded if they are already on other medical therapy. And as you can really see here, that riociguat really improved patients' 6-minute walk distances, and it decreased their PVR, decreased their NT-proBNP, and every hemodynamic variable improved with riociguat, which led to the approval of this medication for patients with inoperable CTEPH or residual PH after PEA surgery. And I think this also goes to one of the questions that is being asked by audience. So how many patients would get Adempas in our practice after PEA?
In our practice, I would say before PEA, majority of them get it, because you want to give them the FDA-approved therapy. After that, I think our data is in line with the data that's already been published. About 50% of patients do have some amount of residual pH after the PEE surgery.
So our experience mirrors what has happened, at least the UK experience.
So then the question would be then why do they have this residual pH? And I think the severity of pulmonary hypertension after the PTE surgery is not as much as it was prior to. That's an important factor to remember. Number one, and number two is that as it's a progressive disease, if they don't get the treatment, they will definitely progress, as we have seen time and time again.
I think the small vessel involvement is, that's something that you can't really reverse. Even though the PVR drops after surgery, it probably never normalizes, and
Right. The other thing to note is that just as with an endarterectomy that's performed on the systemic side, an endarterectomy that's performed on the pulmonary side, where you're removing the intima and exposing really the media to the bloodstream, it creates a highly thrombogenic surface, highly thrombogenic. And you've got a situation over here where you've got low pressure, high flow, but low pressure. And I think this is speculation, but in a patient who may have an additional hypercoagulable condition, the idea of small vessel thrombosis happening immediately post-op should not be discounted. So I think the role of early aggressive anticoagulation is extremely important in these patients, partly for that reason.
So what would you use as an anticoagulant then?
Well, our practice over here is to initiate the patient on heparin as soon as the chest tube output falls below a certain level. And so obviously it becomes important in these patients who have undergone circulatory arrest and who will have a natural coagulopathy from it, that the surgeon be especially meticulous to spend as much time in the operating room as possible to get the best hemostasis possible before closing the chest, so that you can start anticoagulation earlier than you might normally do. So this is one of the many reasons why this surgery is qualitatively, you know, a little more challenging, just because you have to be super careful.
And chest 2 was again, you know, a longer follow-up, and again, it just continued to show that riociguat was continually effective in these patients past the 12 weeks. And I'll let Dr. C talk about MERIT and other other medications which have been at least studied in this population.
So the MERIT trial looked, it was a phase 2 trial of macitentan and CTEPH, and the trial actually showed that over a course of 16 weeks led to functional improvement, also led to hemodynamic improvement with decreased pulmonary vascular resistance. Now, I think with that said, MERIT trial compared to the riociguat trial it's a much smaller trial, and they also permitted the use of other agents outside of just macitentan alone, versus in the CHEST 1 trial that it was purely inoperable or recurrent disease, and also patients who hadn't had other medical therapy previously. So I think that was an important thing to note, and I think going forward we'll probably know more about the role of macitentan in CTEPH.
Yeah, it's currently still not approved. I think the FDA has asked for more information, so I think probably there are going to be more studies looking at the use of ERAs. Of course, you know, an earlier ERA was studied, which was bosentan, again in a smaller study. But even though there was improvement in PVR, it did not really meet the co-primary endpoint of 6-minute walk and PVR. So I think there may be some differences in, you know, different ERAs, and obviously the study was also very small, so, you know, we won't know. So hopefully we'll get more data with ERAs in this population.
Perhaps for our audience, you could just broadly outline the 4 groups of drugs, 3 or 4 groups of drugs that are available, and the different ways in which they work.
So the mainly 3 pathways which, you know, we try to target is nitric oxide pathway, and the endothelin pathway, and the prostacyclin pathway. So in the nitric oxide pathway, there are PDE5 inhibitors and SGC stimulators, and in ERAs there are, you know, just selective endothelin receptor antagonists and non-selective endothelin antagonists. And for the prostacyclins, there are IV therapies which actually are analogs, and now there are receptor agonists as well, which are oral. So again, I think the only approved therapy is in the nitric oxide pathway, which is riociguat. Everything else, I mean, I think we all have experience having used them off-label, but you know, nothing's really approved for at least for CTEPH.
Yeah.
At least in US.
At least in the US.
Yes.
Right.
So now, you know, this is very recent, and I think this year there have been one meta-analysis, and there was a report that Dr. C is going to talk about comparing BPA versus riociguat.
So I think, you know, up until recently, we don't really know the effects of BPA versus medical therapy. The meta-analysis seems to suggest that from a hemodynamic standpoint, PVR standpoint, that there may be more of a benefit from with BPA versus with medical therapy. But interestingly, from a cardiac output standpoint, that it may have been reversed, which there are some theories out there, but I think at this point it's still relatively unclear as far as which one is more beneficial than the other. And so this year at the European Respiratory Congress, they presented the RACE trial, which is basically a head-to-head comparison of riociguat versus balloon pulmonary angioplasty. And at least the data that was presented at the conference, there's significant hemodynamic improvement and functional class improvement in the BPA group over medical therapy group. Now, with that said, the medical therapy group still saw a significant benefit, so I don't think that should be discounted. And I think going forward, it's interesting to see whether there is an interplay between the two and whether both therapies should be considered in patients who are not operable, either from a technical or personal standpoint.
No, I completely agree. I think this field is, as we talk, undergoing changes in management, almost on a yearly or few month basis. So I think eventually, that algorithm we talked about is probably going to change over the next few years.
It's very exciting to see the increasing use of BPA, which really in this country has happened over the last 3 years, and
Correct.
in Europe and in Japan obviously much earlier, but even then we're talking the last 5-6 years, and what we're learning about it is there's new stuff happening all the time, and what it's introducing is this very shaded and nuanced way of dealing with this condition, where I can easily see us using a blended way of managing the patient with medicine, surgery, and BPA, all in the same patient. And it's all evolving, and it's another reason why, having a team approach. And I think you pointed this out. This is really like transplantation. This is
Right.
not something you can do as an individual. You need a collection of people, and it's.
So do you think it's important to have both thromboendarterectomy, a PTE program, and a BPA program in the same center?
Oh, I completely agree. I think we are going. It's almost like treating coronary disease. You need to have a surgeon being able to do bypass at the same time being able to do PCI. So I think there are, as we've discussed, few. Different levels of disease require different approaches, and I think that we are sort of approaching this very similar to coronary artery disease, I feel.
So I just want to add one more thing, that that is very important to have a multidisciplinary approach to this disease, to have these patients evaluated by the surgeon, by the CTEPH experts in a form of a formalized evaluation, so that everything is reviewed and there is a formalized plan for that individual patient.
No.
So it's very important to have these patients referred to a CTEPH program and have this evaluation done
And
at least once.
If I could add to that, it's not only important in the preoperative assessment of these patients, but in the postoperative phase of these patients. I think a team approach to managing these patients is also critical, just like it is with transplant patients, because the management is very nuanced. And the outcomes depend upon those nuances.
That's right. And just to sort of wrap up now, again, just a few other things in terms of anticoagulation. At least in our center and a lot of other centers, warfarin still continues to be the preferred choice of agent. And just recently, like 2 months ago, there was a study from UK again, suggesting that there may be a small benefit to using warfarin. Again, small numbers, overall recurrent PE rates in CTEPH patients are low. Out of the 800 patients they looked at, only 22 patients had a recurrent event. So you're looking at a 5% event rate, well, even less than that, 2 to 3% event rate. So very low event rate, but yet looks like there may be a benefit to warfarin. And we have stepped away from using IVC filters unless anticoagulation is a problem. And in triple positive antiphospholipid antibody syndrome patients, definitely warfarin is the choice. And sort of going back to our patient, she actually responded very well to medical therapy, where her PVR normalized. She's NYHA class 1. She got off oxygen. We continue to monitor her every 6 months with an echocardiogram and yearly with a right heart cath, and her PVR continues to be the same. So I think, at some point, if her functional class, were to deteriorate, or the right heart would, show signs of dysfunction, and at that time we might revisit consideration for BPA in this patient.
How often do you actually repeat these assessments?
We are doing 6-month intervals echo and maybe a yearly right heart caths. Again, this field is evolving. I think
Exactly.
there is no right answer there.
Right.
So
It also depends on how the patient is doing
correct,
and progressing.
absolutely.
So.
So I think with this,
I'd just like to make one comment about BPA and how it differs from PCI. On the surgical side, we're performing an endarterectomy in a pretty similar fashion to the way we might do it on the systemic side. But the difference between BPA and PCI is that PCI is dealing with vessels that have got atherosclerosis, and BPA is dealing with vessels that do not have atherosclerosis. And as a result, when you treat the BPA, as Huie pointed out earlier, and you just create a channel, you go back later and you see that it's a much bigger channel than you originally created. This is a reflection of the fact that the artery actually remodels. And you don't see this remodeling on the systemic side when you do a PCI, but you do on the pulmonary side. So it's a fascinating difference in the in the thing, which is very encouraging, and actually, in my view, carries the potential for BPA to be properly applied, even more successful in this area than PCI is for coronaries. Yeah.
So that's why lungs are very important and different than the systemic circulation.
all right, I think this way I'd like to thank everybody for joining us for DeBakey CV Live, and tune in next time.
Thank you.
Thank you all.
Thank you.